Let's talk about weight loss medications in a clear and simple way. Patients are hearing one thing online, providers often feel rushed, and social media keeps making it sound like every new medication is either a miracle or a disaster. These medications are powerful tools, but they only make sense when people understand what hormones they are working through and what the hormones actually do and why that foundation still matters no matter if a patient's on medications. The first thing is to understand is not all of these medications are doing the exact same thing. People lump them together and just call them GLP medications, but that's not really accurate anymore. Wegovy and Ozempic are mainly GLP medications. The generic name is semaglutide. Zepbound and Mounjaro, which are exactly the same, one's used for diabetes and the other used for weight loss, work only through GLP-1 and GIP. Then you have newer medications that are being studied, something called retatrutide, which appears to work through GLP-1, GIP, and glucagon. That difference matters because each added hormone changes how the body handles appetite, fullness, blood sugar, and energy use. GLP-1 is one of your body's natural slow down and settle hormones. When you eat, GLP-1 helps signal to the brain that food is coming in. It helps you feel satisfied sooner. It slows down how food quickly leaves the stomach. It helps blood sugar stay smoother after meals. So, in simple terms, it helps a meal feel more complete. It lowers that constant pressure to keep eating, to keep searching, to keep snacking. That is the basic story of Wegovy and Ozempic. It is mainly amplifying that one pathway. Zepbound or tirzepatide is broader. It works on GLP-1 too, but it also works on GIP. GIP is another hormone released with eating, and the easiest way to understand it is this. It seems to help the body handle incoming energy more effectively. It interacts with insulin a little bit more, fat tissue, and brain signaling in a way that actually improves energy handling and metabolic response. So, Zepbound is not just quieting appetite more strongly, it is also working through different pathways that can improve how the body deals with fuel. It is not just a louder appetite suppression, it works on a broader physiology. Then comes retatrutide, which people probably haven't heard of yet. This adds glucagon to the story. Glucagon is often misunderstood because people hear insulin and glucagon and they think one is good and the other is bad. That is not how the body works. Insulin helps move energy into tissues and lower blood sugar after you eat something. Glucagon helps mobilize stored energy when the body needs it. That is what makes retatrutide, which I'm sure you'll hear by next year or later this year, very interesting. It not only helps people eat less, it helps promote energy expenditure, helps the body use stored fuel more aggressively. And that does matter because it means that these newer medications are not just shrinking intake, they are also influencing both sides of the equation what comes in and what the body is doing with that fuel. They can promote energy expenditure too. That means the body may be using more. And if the body is using more, that makes it even more important that people are not just accidentally underfueling and underhydrating. This is where things get messed up all the time. A patient's appetite gets quiet, the fullness becomes stronger, the stomach empties slower, and the person thinks, I guess I barely didn't eat anything today. But that is not the right lesson. In many cases, the body still needs a lot of support. The energy expenditure has increased, your metabolism has boosted. So that means you might actually need more food and more liquids. But it's just about being mindful of that. Sometimes more intentional support than before. And that is one of the biggest truths that both patients and providers need to understand better. These medications can indirectly mute both hunger and thirst signals. They reduce urgency, they slow the gut, they lower appetite drive, and make people less aware of their usual body cues. So I hear this all the time. A patient says, I just forgot to eat, or I haven't really had much water today, but I feel okay. That is not always a good sign. Sometimes that means that the volume of the body's signaling has turned down so much and the person is drifting into underfueling and underhydrating without realizing it. That is why some patients say things like, it worked the first week, but not the second week, or my body just got used to it. A lot of the times, the medication did not stop working. What actually happened is that the person started eating too little, drinking too little, getting less overall input, and their body started pushing back underneath the medication. Ghrelin rises, stress chemistry rises, fatigue builds, dehydration builds, constipation builds. The person feels worse and assumes that they need more of a dose, when sometimes what they really needed is more structure. That is also why side effects are misunderstood. People blame the medication for everything when sometimes the medication is simply exposing poor support underneath it. Muscle loss is a good example. These medications do not selectively attack muscle. Muscle loss happens when the weight drops quickly, protein is low, resistance training is absent, and total intake stays too low for too long. Hair loss is similar. Hair is not essential for survival, so when the body senses low energy availability, low protein, low iron, low zinc, or major physiological stress from rapid weight loss, hair gets deprioritized. Fatigue is often a fluid and fuel story as well. Constipation is often a slow gut plus low fluid plus low fiber story. Mood changes can also come from underfueling. Now let's talk about the older medications as well, because they still matter and they can each solve a different problem. Phentermine mainly works by stimulating the nervous system. It raises alertness and suppresses the appetite. In real life, that means many people feel less hungry, more focused, and more alert. But that can also create a wired but depleted state if it is not handled properly. People may eat less, drink less, sleep worse, or become more anxious. So with phentermine, hydration, sleep, and meal structure matter a lot. Phentermine can release a hormone called norepinephrine or energy hormone, same hormone that coffee releases. So that can also increase energy expenditure. When your energy expenditure increases, you lose more liquids. So some people will have more anxiety with that because of the underlying problem of not drinking enough. So what happens when your body's in a dehydrated state, the first thing that goes up is your heart rate. So that's why people in the hospital feel great after getting IV fluids because they replenish what they lost. So it's very important to hydrate well on all of these medications. Topamax or topiramate works more through the brain. It can reduce appetite, reduce reward from food, and lower cravings. Some people notice soda tastes different. Some notice highly processed food loses more of a pull, but it can also make people undereat or feel mentally slower if they are not monitored well. Again, the prescription is not enough. The explanation matters. Topamax is also used for migraines, mood stability. Metformin is a little bit quieter. It's not actually a appetite suppressant, but improves your insulin sensitivity and can smooth out blood sugar swings. When blood sugar is steadier, appetite often becomes steadier. Wellbutrin, or bupropion, works through dopamine and norepinephrine pathways. In simple terms, it can help reduce emotional eating, lower reward driven eating, improve motivation, and sometimes decrease appetite. It's not really a fullness medication, it is more of a brain drive medication. For the right patient, it can be incredibly powerful. For the wrong patient, it can worsen anxiety or irritability. So, again, the better question is not which medication is the best. The better question is what problem are we trying to solve? Also, know that Wellbutrin is used for smoking cessation, depression, and anxiety. And this medication, you need to drink a lot of fluids. Now, let's get to a more simpler truth. These medications are not magically fixing every comorbidity on their own. A huge part of the benefit comes from what happens when fat tissue or adipose tissue shrinks. Fat tissue is not passive, it is an active tissue. It sends inflammatory signals. It affects insulin sensitivity, affects blood pressure, liver, fat, sleep apnea, joint load, reproductive hormones, and more. So, when the fat mass decreases, especially visceral fat, the fat around our organs, inflammatory markers often improve and many downstream conditions improve with it. That is not magic. That is the biology of reducing pathological fat burden and improving the internal environment. So, when people say these medications improve cardiovascular disease, sleep apnea, blood sugar, blood pressure, liver inflammation, mobility, and so on, what is really happening is the shrinking of the fat tissue changes the whole system. The internal environment becomes less inflamed, the metabolic load comes down, the body starts functioning better. The medications may help drive that change, but a lot of the downstream benefits come from what is happening as the fat tissue becomes smaller and quieter. So it is not the medications directly that are improving all of these things, is really the habits behind the medications because people can have the same effect without medications if they have a good dietary regimen and a good fluid structure around their lifestyle. And clinically, many providers have seen this across the board. Even though approvals right now may not be as specific to those conditions, many of us have seen improvements in all parameters: better blood pressure, better glycemic control, better fatty liver markers, less joint pain, better mobility. People even have better energy once the patient is properly supported. Another point that really clearly needs to be said is that people do not always have to go up on their dose. Yes, there are starting doses. Yes, titration matters for insurance purposes, but more is not automatically better. In fact, the higher you go, the stronger the signal suppression can become. Fullness gets louder, gut emptying slows more, hunger gets quieter, thirst cues can often get quieter. And at some point, some patients stop really knowing what their body actually needs because the medication is doing too much of the listening for them. That is why some people do beautifully at lower doses. My patients decide if they want to go up any higher, because if they're feeling great, there's no reason for them to go up any higher. Patients can still hear enough of their body to build rhythm at lower doses. They can still tell when they need more protein, fluids, electrolytes, or an actual meal. They can build habits. They can stay connected to their physiology. For many patients, that matters more than chasing the biggest possible dose. This is where good prescribing becomes real medicine. A provider should not ask, "Are you losing weight?" A provider should also ask, "Are you hydrated? Are you moving your bowels? Are you dizzy? Are you getting enough protein? Are you thinking clearly? Are you losing strength? Are your habits actually forming?" Those questions matter just as much as the scale. I told you before that the scale number or the weight is not going to reflect how much fat tissue you're actually losing. I could have the same patient come in 2, 3 months later, their weight maybe moved 1 or 2 pounds or none at all, but their waist has decreased several sizes because their fat tissue is shrinking and sometimes muscle weight can actually increase the weight number. So, my main question for my patients is, how are your clothes fitting? How are your joints feeling? How do you feel overall? Because there will always be people who rely heavily on the medication, eat only when they're hungry, drink only when they're thirsty, and still lose weight. And I have to remind my patients every single time, don't wait for the hunger. Do not wait for the thirst. Get ahead of it so you could develop that routine. That absolutely happens. But from a long term habit perspective, that can become very dangerous. And if the coverage is lost through their insurance, supply is interrupted, or they simply want to stop, they may suddenly realize they never learned how to live without the medication doing the job for them. That is why some people struggle tremendously when they are off. It is not because they are weak, it is because the medication was doing the work and their habits never caught up. On the other hand, many patients can come off and still do well and continue losing weight because by that point, their lifestyle habits are doing most of their work. They know how much fluid they need, they understand hunger, they understand when they're actually underfueled. They're not guessing anymore. That is the difference. That is why maintenance should be individualized. Once a patient reaches a lower maintenance dose and their foundation is strong, it makes sense to ask whether escalation is really necessary. Not to force them down, not to force them up, to ask, to educate, to decide based on real physiology and real life, not panic over a plateau. And if there's a plateau, that should not automatically mean higher dose. Plateaus can come from undereating, underdrinking, low activity, constipation, poor sleep, loss of muscle, or simply the fact that the body has adapted to a lighter weight. Sometimes the answer is not more medication, sometimes the answer is better support. That is why supplementation may matter too, but not in a random way. Not supplement overload, the essentials. Adequate protein is not optional, fluids are not optional. Electrolytes often matter more than people realize, especially sodium, potassium, and magnesium. Fiber matters if tolerated, especially for bowel regularity and gut support. Some patients also need to pay attention to iron, B12, vitamin D, and other basics if their intake has dropped for too long. Providers should not just say eat more protein and move on. They should explain what underfueling actually feels like, what dehydration looks like, why constipation actually happens, and what the person needs to watch out for. That is the real responsibility here. Prescribing these medications without educating patients on hunger, thirst, hydration, bowel function, protein, and muscle preservation is, in my opinion, incomplete care. And the last thing I want to say is this: these medications are not cheating, they are not miracles, they are tools. Powerful tools, yes, but still tools. Wegovy is mainly a GLP-1 tool. Zepbound is a GLP plus GIP tool. Retatrutide, if that comes out, appears to be GLP plus GIP plus glucagon tool. The quieter the medication makes a noise, the more important it is for us to teach the patients how to listen. Because if someone learns how to understand their body when the noise is low, they may be able to keep going even when the medication changes or if they come off it. If they never learn that, they stay dependent on something outside of them to run the whole system. And that is why this topic matters not just for patients, but providers too. We are not just prescribing weight loss medications, we are shaping whether someone builds long term body literacy or just temporarily appetite suppression. Because underneath every medication, every plateau, every craving, every side effect, and every success story, the body is still speaking in signals: hunger, fullness, thirst. And that is exactly where the next season begins. Hormones are running the story. I'll see you in the next episode.